Welcome to all of you to the Department of Surgery presentation. We are presenting a case across two units, namely Unit 2 and Unit 1, same patient, and with a very interesting title, and I will request Dr. Kamal to start the case.
Thank you, sir. Good afternoon, everybody. I welcome you all for Surgery Unit 1 CCR, title of which is One Man with Magma. I think with title, you must be able to find out what we are going to discuss. It is a Man-1 syndrome. The Man-1 syndrome is commonly remembered with a simple mnemonic triple P: parathyroid, pituitary, and the pancreas. These are organs which are involved in Man-1 syndrome. But the diagnosis and the management of Man-1 syndrome is not as simple as this mnemonic is. There are certain challenges in the diagnosis and management, what we are going to discuss in today's CCR. And for that, I would like to call Dr. Amrita. She will tell the case details, and later on it will be followed by other departments. Thank you. Dr. Amrita.
Thank you, sir. Good afternoon, everyone. So I'm here to tell a tale of a man with Men-1. So starting with history, Mr. SK, a 27-year-old gentleman from Bihar, a service engineer by occupation, presented to us with complaints of recurrent episodes of altered sensorium and sweating and palpitation since last 2 years, and increased appetite and weight gain since last 1 year. He experienced his first episode of altered sensorium as soon as he woke up from his sleep. The episode was described by a bystander as the patient was not able to recall the event. He apparently exhibited altered behavior and also was confused, disoriented, and agitated. This episode was relieved by food intake. There's no history of loss of consciousness, no history of abnormal movements of limb, eye rolling, tongue bite during the episode, or myalgia or confusion after termination of the episode. He's had similar episodes, usually after prolonged fasting or following strenuous physical activity. These episodes were associated with sweating, palpitations, and tremors. Episodes usually terminated within minutes after eating. To begin with, he had 1 or 2 episodes per month, which later increased to 4 to 5 per month. Along with this, he gives us a history of weight gain, which is associated with increased appetite and increased intake of quantity and frequency of food intake. As the frequency of episodes increased, he also started eating frequently in anticipation of an episode, resulting in rapid weight gain of 18 kgs in 1.5 years, which is almost 24% gain compared to his previous weight. There was no history of chest pain, breathlessness, or postural variation of symptoms. There's no history of burning, micturition, dysuria, hematuria, myalgia, constipation, mood disturbances, or bony pain. Since by this time we'd already been sure that his symptoms were resembling that of neuroglycopenic symptoms, so we wanted to rule out the other possible endocrine disorders in the patient. There's no history of visual, and these were for hypoglycaemia. There's no history of visual disturbance, increased frequency of micturition, or loss of libido. In past history, there's no history of surgeries in the past or prolonged admission or medication, no history of intake of any over-the-counter drug or alternative medicine, no history of any psychiatric illness, and no history of trauma. He's a non-smoker. He does not consume alcohol. His sleep cycles were disturbed due to episodes of hunger. He had a normal bowel and bladder habit, and no history of drug abuse and no history of emotional disturbance in day-to-day life. This is his family pedigree chart. This shows our patient index case. And this shows us that none of his relatives, both paternal and maternal, had similar symptoms. The only significant history we have is that his paternal uncle suffered from lung cancer. On examination, the patient was conscious, oriented to time, place, and person. His vitals were the pulse 72, blood pressure 116/80, respiratory rate 22, temperature of 98.6, and a saturation of 98% in room air. He had a weight of 93 kgs and a BMI of 32. There was no pallor, icterus, cyanosis, clubbing, generalized lymphadenopathy, or pedal edema. He had multiple skin tags over the left wrist and bilateral axilla, and several papular lesions with normal adjoining skin all over the body. The image here shows the same over the trunk of the patient, multiple papules. And these were asymptomatic. On systemic examination, he had a protuberant abdomen with no visible or palpable masses. The rest of the systemic examination was unremarkable. So to summarize, we have a 27-year-old gentleman with no known comorbidities, with recurrent episodes of altered sensorium, sweating, and palpitations for the last 2 years, exacerbated after periods of prolonged fasting and relieved from taking food, with a significant weight gain and increase in appetite for the last 1.5 years. And on examination, he was obese with a BMI of 32, with multiple skin tags and papules present over the body, with near normal systemic examination. So by this time, we were sure that the patient was having neuroglycopenic symptoms associated with sympathetic hyperstimulation. And our differentials were in neuroglycopenia due to insulin excess. Insulin autoimmune disease was a possibility. Adrenal insufficiency was a third differential diagnosis, and followed by maybe a last differential was psychiatric illness, maybe an eating disorder or an anxiety disorder. So to start with, our workup was directed towards the workup of hypoglycemia. We started with routine investigations. His complete hemogram was within normal limit. His liver functions were within normal limit, whereas his kidney functions revealed a raised total calcium level, and phosphates are within normal limit, and the rest of parameters also within normal limits. In hypoglycemia workup, we admitted the patient, we kept him fasting. Once he developed symptoms as he described earlier in history, we measured the blood glucose, insulin, and C-peptide levels at that moment in 2 different occasions. So the blood glucose at that particular time, the lab values were 36 and 31. And his insulin levels were inappropriately high for such a low glucose level. They were both 99 and 130, way above the accepted limit of less than 25. And C-peptide levels also were raised. So to complete our hormonal workup, we got the whole panel of endocrinology workup done. He had a raised prolactin level of 44.2, and an intact PTH was raised, it was 183.4, and insulin-like growth factor 1 also was raised, which is 281. And in 24-hour urine evaluation revealed raised urinary calcium with a normal urinary phosphate, and creatine protein also within normal limit. So we arrived at a provisional diagnosis of a patient with hyperinsulinemic hypoglycemia with a parathyroid hormone dependent hypercalcemia with hyperprolactinemia, probably a MEN1 syndrome. So to anatomically characterize and localize a possible neoplasm that we were suspecting, the patient underwent extensive radiological and nuclear imaging. To discuss the radiology, I'd like to invite Dr. Rajendra.
So, good afternoon. This point, the patient suspected of MEN1 has been imaged for all the three organs, starting with P. So, first of all, we imaged the pancreas because of the hyperglycemia and hypoglycemia and hyperinsulinemic symptoms. So, in this case, we see there is a arterial enhancing lesion in the head of the pancreas, which shows washout on the venous phase images, suggesting of a neuroendocrine tumor. At this point, we also see there is a right proximal uretary calculus with mild hydronephrosis. And this repeat the pancreas one. So, sir, this one, there is a arterial enhancing lesion in the head of the pancreas in around 2 into 1 centimeter. And the same arterial enhancing lesion, this is the venous phase image, shows washout. So suggestive of a neuroendocrine tumor. So, the next imaging done for the pancreas on 15 January also showed a different lesion in the tail of the pancreas. This is separate from the head lesion we also seen in the CT images. And the pituitary also imaged, which showed no definite lesion in the, it is essentially normal. And the parathyroid also imaged with 14 neck CT images. And in this case, we see there are 2 arterial enhancing lesions in the located in the posterior to the right to the left lobe. They are showing arterial phase enhancement and washout on the venous phase images. These 2 lesions also seen in the coronal images. This is the elongated lesion in the posterior to the right lobe, and this is the tiny lesion in the posterior to the left lobe. So we got in this case the 2 lesions in the pancreas suggestive of neuroendocrine tumor and 2 parathyroid adenomas. So the diagnosis in this case would be MEN1 syndrome with multiple neuroendocrine tumors in the pancreas and 2 parathyroid adenomas. So next I will call Arun Raj to describe the nuclear imaging findings.
Good afternoon. This patient was referred to our department for evaluation of these pancreatic lesions and the parathyroid adenomas. Initially, this patient underwent Doudonov PET-CT after injection of 3 millicurie of the radiotracer, and the images were done after 1 hour. These are the this is the maximum intensity projection image of the Doudonov PET-CT. we can see normal physiological uptake in the liver, spleen, kidney, and the urinary bladder. And we can also see one focal uptake in the region of medial to the splenic hilum. These are the transaxial non-contrast CT and the fused PET-CT images. We can see focal accumulation of radiotracer in the tail of pancreas with no significant CT changes, and there is no focal accumulation in the head region. Since there was one lesion in CCT and MRI in the head of the pancreas, and this daughter of PET-CT is less sensitive for insulinomas compared to other neuroendocrine tumors. He also underwent 68 gallium DOTA extended PET-CT. This is another PET-CT which target the glucagon-like peptide 1 receptor, which is overexpressed in insulinomas and which is normally seen in the beta cells of pancreas, and it is overexpressed in insulinomas. This PET-CT has a high sensitivity and accuracy for detection of insulinomas. Since this patient had 2 lesions on MRI, and to find out which one is the insulinoma, we did the scan. And as you can see, the image is the maximum intensity projection image. We can see focal accumulation in the medial to the right kidney. These are the transaxial CT and PET-CT images. We can see focal accumulation of radiotracer in the head of pancreas corresponding to the arterial enhancing lesion seen on CECT, and there was no accumulation in the tail lesion. So after this, we concluded that the lesion in the head of pancreas is likely the insulinoma, and the other one is the non-insulinoma in it. This patient also underwent Sestamibi scan for the evaluation of parathyroid adenomas. These are the serial planar images we did after injection at 15 minutes, 50 minutes, and 2 to 3 hours. The initial images, we can see normal accumulation in the salivary glands, myocardium, and both lobes of thyroid. And on serial imaging, we can see a gradual washout of radiotracer from the thyroid with the retention of radiotracer on both sides of the neck. We can see 2 focal accumulation in the delayed images. These are the non-contrast CT and the fused PET-CT images. There are 2 soft tissue density lesions behind the one behind the right lobe of thyroid, one behind left lobe of thyroid, which shows focal increased radiotracer accumulation consistent with parathyroid adenomas. Thank you.
Now we are almost arrived at a definitive diagnosis of a patient with Meniere's syndrome with bilateral parathyroid adenoma and an insulinoma and a renal calcular disease. So we had planned, since hypoglycemia was more life-threatening when compared to hypercalcemia, we had planned to go ahead with management of the insulinoma in pancreas first, followed by parathyroid. So for pre-anesthetic evaluation and optimization, I'd like to invite Dr. Ajisha to discuss the case.
Good afternoon, everyone. So these patients come to us for primarily 2 surgeries, that is parathyroidectomy and Whipple's procedures to remove the insulinoma. So I'll be discussing the perioperative concerns for insulinoma. Recurrent hypoglycemic episodes, if severe, may cause neurological damage, which must be evaluated and documented in the preoperative period. These patients are often obese, which adds to the difficulty in management of their airway ventilation as well as drug metabolism. Prolonged fasting in the preoperative period is avoided in these patients, and so IV fluids must be continued while they are nilperoral. The lowest level of blood glucose at which the patient becomes symptomatic must be ascertained for appropriate blood sugar management in the perioperative period. And the signs and symptoms of hypoglycemia may often be masked under anesthesia. So strict blood sugar monitoring has to be done on an hourly basis, which may mandate inserting arterial lines and central venous access, apart from the other indications for the surgery. Glucose-containing intravenous fluids may require to be given intraoperatively to maintain normal glycemia. And balanced general anesthesia with a thoracic epidural or a bilateral paravertebral catheter is considered optimal for perioperative management and pain relief. One must also be mindful of the insulin surges that may occur during tumor manipulation, and so which again mandates that strict blood sugar monitoring has to be done intraoperatively. After the tumor resection, sometimes these patients go into hyperglycemia, which would be picked up on a blood sugar monitoring and which needs to be managed accordingly. Perioperative concerns for parathyroidectomy patients. They often present with hyperglycemia, which may predispose them to cardiac arrhythmias due to the shortening of QTc interval. They may have unpredictable responses to the muscle relaxants. Some of them may show increased sensitivity to the long-acting muscle relaxants that we often use, and a train of 4 monitoring may be used intraoperatively. Their osteoporotic brittle bones mandate that we carefully position them for the surgery, as they're prone for pathological fractures. The surgical positioning per se mandates that the arms are put by the side and the head end is away from us, which reduces our access to the endotracheal tube and the IV lines, which makes us absolutely uncomfortable. Intraoperative injury to the recurrent nerve primarily or the superior nerve can lead to post-operative hoarseness of voice, stridor, or aspiration in the post-operative period. A bilateral recurrent nerve injury can lead to complete obstruction in the post-operative care unit that may mandate a re-intubation and steroid cover in the post-op period. So as a rule, a preoperative documentation of vocal cord mobility on indirect laryngoscopy and checking of vocal cord mobility just prior to the extubation is done for all of these patients. Major vascular injury, although rare, can cause hematoma formation and complete airway compromise, which would again require an emergency re-intubation and wound re-exploration, for which the patient needs to be taken back to the OT. So at the end of parathyroidectomy, some patients may go into a transient hypocalcemia, which may present with tetany, circumoral tingling, and seizures, which mandates the serum calcium monitoring in the post-op and supplementation if required. Thank you.
I'd like to invite Dr. Brijesh to discuss the surgical management of the patient.
Good afternoon, everyone. On the basis of thorough clinical history, biochemical investigation, and biochemical and radiological investigation, the diagnosis was Menuhin syndrome comprising the pancreatic insulinoma along with parathyroid adenoma. So our plan was exploratory laparotomy with enucleation versus pancreatic adenectomy with bilateral neck exploration. So in operative steps, the exploratory laparotomy was performed by midline incision. Pancreas was exposed by the hepatic mobilization, cauterization, and after giving the incision of lesser shape. After pancreatic exposure, pancreatic tumor was localized by the manual palpation, but due to the poor delineation, we used the intraoperative ultrasonography, which revealed 2 pancreatic lesions. One is located in the pancreatic head near to the pancreatic duct and ampulla. So we plan for the pancreatic duodenectomy, and another lesion is located in the tail of the pancreas away from the pancreatic duct. So we plan for the enucleation. So our intraoperative plan was the pancreatic duodenectomy for pancreatic head lesion with enucleation of pancreatic tail lesion. So we follow the standard step of pancreatic duodenectomy, and resection of the pancreatic head lesion tumor was done. And after the resection, reconstruction was performed by the pancreatic jejunectomy with Duncan's technique, followed by hepatic jejunectomy, followed by gastrojejunectomy, along with feeding jejunectomy. These are the specimen of resected. These are the resected specimen of pancreatic tumor. Here the pancreatic tumor is located in the head of the pancreas, and the second is the pancreatic tumor located in the tail of pancreas. After the post-operative period, blood sugar was normalized, and feeding was started on the post-op day 5. In post-op day 6, some bile is coming out in drain output. So we plan for the upper GI endoscopy with head scan, which was normal. And there was some surgical site infection was noted on the post-operative 14. So we managed with antibiotics, and patient was discharged on the post-operative 38. And in follow, patient was refused bilateral neck explosion in immediate follow-up. So patient was readmitted after the 1 year for the bilateral neck dissection. Conventional bilateral neck dissection performed for the parathyroidenoma with use of methylene blue for easy localization of parathyroidenoma intraoperatively. These are the intraoperative findings with right superior and left superior parathyroid gland is enlarged, and 2 bluish nodules is found in the right thyroid lobe. And both parathyroid was removed along with the 2 thyroid lobe nodules. And post-operatively, significant intraoperative parathyroid hormone was reduced. And post-operatively, serum calcium level was normalized, and patient discharged on the post-operative 3. Now I'm invited to my Chipra ma'am for the.
Good afternoon, everybody. So we received batches of the first batch of specimens was received in 2020. We received 5 specimens in this, which included pancreatic for duodenectomy specimen, the enucleated lesion from the tail of pancreas, a specimen which was sent as skin tag, suprapancreatic lymph node, and gallbladder. So these are the sections from the pancreatic lesion. In the head of the pancreas, we found a lesion which was 1.9 centimeter in maximum dimension. This is the lesion, and this is the normal pancreas. The lesion, in this, the cells were mainly arranged as nests and trabeculae, and they were suggestive of a neuroendocrine tumor. One of the lymph nodes, which was resected from the specimen out of 11 lymph nodes, showed a tumor deposit from the same tumor. In addition, when we subsequently did immunohistochemistry, the tumor cells were immunopositive for synaptophysin. These are all markers for neuroendocrine differentiation. Over here, you can see the normal islets of pancreas, which were also positive for the same. Chromogranin was also positive. INSM1, which is insulinoma associated protein, it's like specific and highly sensitive for neuroendocrine differentiation, was also present. It's a nuclear stain as compared to the other 2, which are cytoplasmic stain. The proliferative index was about 6% in this tumor. We further performed specific IHC for the hormones, and the tumor was positive for insulin. These are the normal islet cells, but was negative for glucagon and somatostatin. Another bit which was sent to us was the tumor from the tail of pancreas. It was a small tumor, about 0.6 centimeter in maximum dimension. And these are similar tumor cells, which are immunopositive for synaptophysin, but they were negative for insulin and the other hormone markers. The MIB1 labeling index in this tumor was about 3%. I could not retrieve the slide of the same, and hence I could not photograph it. This was a specimen which was sent as skin tag. The overlying epidermis was a bit thinned out. There was not much major change, although the collagen bundles appeared a bit thickened. This is the mesenteric stain, which showed a bit of thickening of the collagen bundles. 2 other specimens were sent. The gallbladder showed chronic cholecystitis, and the suprapancreatic lymph node was free of any tumor. Hence, on this particular specimen, which was sent in 2020, our final impression was neuroendocrine tumor measuring 1.9 centimeter in maximum dimension, grade 2, insulinoma, because it was positive for insulin hormone, located in the head of pancreas, showing lymph node metastasis. The one in the tail of pancreas was called neuroendocrine tumor grade 2, and the skin lesion was called collagenoma. We also received, in fact, I reported it yesterday only. Recently, we received these 4 specimens sent together: left superior parathyroid gland, right superior parathyroid gland, and 2 nodules from the right thyroid lobe in the superior pole and the inferior pole. So their weight was not much increased. They weighed, one of them, the left superior one, weighed 27 milligram, 270 milligram, and the right one was, I think, 0.53 grams. So if you see, they are definitely hypercellular. The normal adipocytes, which are distributed throughout the parenchyma, they are lost, and they are arranged as lobules. So what we call this is lobular accentuation. So the architecture wise, it's relatively normal, but the cellularity is increased. So we call this lobular accentuation. At this part, you can make out some vague nodularity to the lesion. This is the right superior one. Over here, we had some amount of normal parathyroid. You can see the interspersed adipocytes, and this is the hypercellular gland. So in case of Men's syndrome, although earlier people used to call it parathyroid hyperplasia, now it has been documented that these are actually multiple small adenomas which are clonal proliferation. So now they call it micronodular adenomatosis, and they don't call it hyperplasia. Both the nodules in the thyroid showed similar morphology of colloid cysts. Hence, in this, the final impression is micronodular adenomatosis, left and right superior parathyroid glands, and colloid cyst thyroid gland. Thank you.
I'd like to invite Dr. Naneshwari Jairam, SR Breast and Endocrine Surgery, to review the literature.
Thank you, Dr. Amrita. Good evening, everyone. By the literature, Menon syndrome, it's an autosomal dominant inherited disorder affecting the tumorigenesis in at least 8 endocrine and non-endocrine tissues. It was first described by Werner, hence it is named as Werner syndrome. It is due to a mutation in the MEN1 gene, which is a tumor suppressor gene, which encodes the menin protein. Now, coming to the clinical manifestations, it is the main known 3 endocrine manifestations are primary hyperparathyroidism, which is seen in more than 95% of the patients, followed by pancreaticoduodenal neuroendocrine tumors, which is seen comprising around 50 to 75%, followed by pituitary tumors. Now, all these 3 major manifestations are not seen in all the patients. It is seen only in around 12% of the affected patients. There are other known endocrine and non-endocrine manifestations. Among them, the most will be the foregut carcinoma, followed by lipomas or collagenoma. Coming to the demographics, it is around, the incidence is around 0.2 per million. It mostly manifests between 20 to 40 years of age, and this expression of the disease is very rare before the age of 10 years. And more than 98% of the time, they display symptoms by 5th decade. Now here we can see the most common it is by in the x-axis we see the age distribution, and in the y-axis the number. It is concentrated between 20 to 40 years. The most common one is for the parathyroid, followed by the gastrinoma, that is the pancreatic neuroendocrine tumor, followed by prolactinoma. Then it is the insulinoma, which is the most common. Now, how do we diagnose? There is diagnostic criteria, that is at least 2 endocrine manifestations or 2 endocrine organs should be affected to call as Menon syndrome. So clinically, a patient with 2 or more Menon associated tumors, either familial way, that is the patient with Menon associated tumors and a first degree relative with Menon, or genetically an individual who has a Menon mutation but does not have a clinical or biochemical manifestations of Menon, that is he might be a carrier. Coming to parathyroid. This primary hyperparathyroidism is the initial clinical or biochemical manifestation, which is seen in around 60 to 90% of the patients. The classical pentad of symptoms, which we call as painful bones, kidney stones, abdominal groans, psychic moans, and fatigue overtone. Now, many times this can be asymptomatic also. Now, we have to differentiate, or it can also be seen sporadically, the parathyroidism. Now, difference between the parathyroidism occurring in men 1 and sporadic is male to female ratio is equal in men 1, whereas sporadic is more common in females. The age at presentation is in the 2nd to 4th decade in men 1, whereas in sporadic it is little late. In the glandular involvement, it is most of the time it is multiglandular and it is asymmetrical involvement of the parathyroid glands. In sporadic, it is 85% of the single glands. The rate of recurrence is high in men 1 due to high proliferative drive, but it is low in sporadic hyperparathyroidism. How do we diagnose? We diagnose by patient should have elevated serum calcium, elevated inappropriated elevated PTH levels, and calcium to creatinine clearance ratio of 0.1. Coming to pancreatic neuroendocrine tumors, this is the second most manifestation, comprising 30 to 80%. And among PNETs, it is the non-functioning tumors which are the most common, constituting 20 to 50%. Coming to the functioning tumors, which are also seen, among them it is the gastrinomas, which are more common, they are around 30 to 40%, followed by insulinomas, which are 15 to 40%. There are other known pancreatic neuroendocrine tumors which are rarely seen in Menon syndrome. Coming to gastrinoma, this is the most common functional pancreatic neuroendocrine tumor seen in men 1. This is first described in 1955 by Zollinger and Ellison. It is associated with men 1 in 25% of the patients. Now, this is seen in gastrinoma triangle, which is bounded by the cystic duct, neck of the pancreas, and the third part of the duodenum. The clinical features will be patients having fulminant peptic ulcer diathesis, acid hypersecretion, along with non-beta islets and tumors of the pancreas. And we should suspect when patients have intractable peptic ulcers, especially jejunal ulcers, persistent secretory diarrhea. Biochemically, more than 1000 picogram per ml elevation of the gastrin associated with increased gastric secretion constitutes for gastrinoma. For our patient who had insulinoma, this is the second most common PNET, which is described by Whipple and France earlier by neuroglycopenic symptoms, which was consistent with hypoglycemia, should have a documented low plasma glucose concentration measured when symptoms were present, and with the relief of these symptoms with administration of glucose. In men 1, around 4 to 8% of them are associated. These are the symptoms which can be transient with the clouded sensorium, apathy, behavioral disturbance, or sometimes they can also present with sensory loss, sometimes with neurological deficit. They will have cardiovascular symptoms of episodic palpitations with increased hunger, nausea, and vomiting. Now, again, these patients, the differences between men 1 and sporadic will be, in men 1, they are seen in less than 35 years of age, they are seen along the pancreas, but here they are less than 1 centimeter and often they are multiple. And around 10% of the time they are malignant. Now, how the diagnosis is, patient, we should document that patient should have a fasting plasma glucose level of less than 45, elevated insulin level of more than 6 microunits, C-peptide level should be elevated more than 200, and patient should be screened for sulfonylureas or other oral hypoglycemic agents. The other manifestation is the pituitary adenoma, which is seen in 30 to 50%. The most common is prolactinoma, which they can present with in women amenorrhea and galacturia, and in men hypogonadism. Very rarely patients can secrete growth hormone leading to acromegaly or even Cushing's syndrome. Sometimes the tumors, when they enlarge, they can compress, causing visual field defects or with manifestations of hypopituitarism. Now, how do we manage? Now, this requires evaluation of parathyroid can be evaluated by ultrasound, Sestamibi scan, if not diagnosed with 4D CT for the pancreas, anatomical localization and also functional localization for pituitary, CT of the sella, if required intraoperative ultrasound. This is the parathyroid localization using ultrasound, Sestamibi and the SPECT CT. And this is the PNET localization of showing the tumor in the head of the pancreas, in the dotonok, which is shown, uptake is seen in the tail, and in the endoscopic ultrasound showing the tumor. Now, whom to operate first is the important thing. Here, usually, the parathyroid should be operated first, and this patient should undergo conventional open bilateral exploration with subtotal parathyroidectomy and concurrent transcervical thumectomy, that is total parathyroidectomy with autotransplantation is also an option. But these patients have also a recurrence. If total parathyroidectomy is done, the recurrence is as low as 0. With the subtotal, it is less than 4%. Persistent is seen in both less than 4%. So for the gastrinomas, ideal, if they are in the head of the pancreas, ideally will be the pancreaticoduodenectomy with the restoration. Insulinoma is the endocrine tumor wherein we can go for enucleation with the help of endoscopic ultrasound. This is with the use of intraoperative ultrasound. And genetic testing is important, which was marked by Larson et al. And the penetrance by the age of 20 years is 50%. So patients should be screened by genetically. For genetic testing, at least 2 or more of the associated tumors should be there in an individual. Either it should be a familial pattern or then a germline mutation should be there in the carrier. Sometimes in an atypical men 1 also, we can test for the genetic testing, patients having parathyroid adenomas before 30 years or patient having a multiglandular hyperparathyroidism or with gastrinomas. Surveillance starts by genetic testing at the age of 5 years for pituitary, by the age of 8 years for parathyroid, by the age of 20 years for the pancreas. If all are negative, continue annually. If they are positive, treat the patients. So this is another entity called MEN4, wherein it presents like MEN1, but it does not have a genetic testing. So pituitary can be treated by medically and also by surgery.
Last slide.
Yes. So these patients, there should be high index of suspicion. They should be identified at the risk individuals and also the family members. We have now preoperative localization techniques and to localize the tumor. And management options include surgical and also non-surgical. And here surveillance is the cornerstone of the patients. Thank you.
Thank you to all the presenters. And this is how the patient presented, workup and managed. The collaboration between the endocrinology, radio diagnosis, nuclear medicine, anesthesia, pathology, as well as the surgeon is very important for the patient management. Thank you.
So I have I'm Dr. Ranjan Yadav from Laboratory Department. In blood investigator finding, we had to mention that total lymphocyte count is 10,000. That is lymphocyte. Whether it is this printing, this writing, or it is total lymphocyte. Total lymphocyte. Because I have NF for nothing, I have NF or total lymphocyte count 10,000. And 10,000 is not enough.
Thank you. May I request Professor Chumber sir was the operating surgeon from both the cases for the comments.
I think the one thing which we emphasized earlier, that this is a collaborative work across 2 units, across many surgeons and many departments, and it could not have been achieved anywhere else. And we had an excellent anesthetist with us, Dr. Anjan and Ajisha, to help us in this. The topic is open for discussion. If you would like to comment or if there are any queries, I beg that we have exceeded the due time.
So was biochemical screening done for the family?
Not as yet. We have not been able to do it, but he has expressed a desire. He has a son who is 11 years old, and he's going to bring the child back. In between, there was a pause for about 11 months, mainly because of COVID. We had to send him back, and he also wanted to go back to his home, and now he has returned, so we could do the parathyroidectomies now.
The post-op calcium level was 7.5. So my IR is just a small query. And since it is just at the upper limit of the...
It is.
So does it make sense to repeat an imaging after surgery to see whether any part was left out?
They have done the imaging, and whatever imaged things they have given us, we have given it all to them. No? Okay, so the PTH has come down markedly. Even the calcium has come down, though we don't expect much dramatic changes in the first 5 days itself. So we'll wait and see.
What about pituitary gland IGF?
Yes, we have investigated him. There is no microadenoma as such. We will keep our eye on him. Many times the pituitary microadenomas will manifest much later on. The prolactin level was initially elevated, and we'll keep an eye on that, and we'll keep him in the loop and get him operated whenever required. Thank you very much.